Good afternoon, everybody. Sorry for the delay. This is our OHA COVID-19 webinar series for healthcare providers. We had a little technical glitch. Hopefully everything is working now. This is Dana Harganani, Chief Medical Officer here at OHA. I'm joined by my colleagues, Dr. Jean, Dr. Smits, and Dr. Sullivan, who are all going to be contributing to today's webinar. We have a lot to share with you today. There's a lot going on and a lot to share. So we're going to try to be as efficient as we can and also save time for some questions. So bear with us, but we're going to jump in. So just a quick overview of what we're going to be talking today. We're going to provide an epi update, knowing that there's a lot of change happening afoot right now with our case numbers and more. We will hone in on new school metrics updates that were just shared recently publicly, and we'll talk about influenza, knowing that this is an important time for that focus as well. We'll talk briefly about a vaccine update, talk about our new pediatric COVID-19 report issued last week, and close with some really important literature updates and answers to some of the questions you've brought forward. So let's dive in. So first, our COVID-19 update, we anticipate that you all are paying attention to this, but as you know, we are in the midst of an additional surge and seeing cases that we have never seen, case numbers that we have not seen previously in this pandemic in Oregon. As of yesterday, we had over 47,000 total cases identified since the beginning of this, over 3,000 hospitalized cases, and unfortunately now over 700 deaths. And as you can see in our epi curve in the background here, you can see that we continue to be on a incline, and we anticipate we're going to continue to see expansion of that incline in these coming days. So a really important time for us to be focusing in on prevention, physical distancing, hand washing, and doing everything we can, and engaging our colleagues, our families, our friends, and taking responsibility with all of us to try to dampen this curve at this moment in time. In our last weekly report that looked at the week of October 25th through November 1st, we had cases that were up 34% from the week prior, and that week prior also was up from the one before. So again, just really highlighting the significance of the surge that we're in right now. We also had an increase in tests by 10%, newly tested individuals during this week. And also we're seeing a rise in our percent positivity of those tests. We're now up to 8.4%, a notable increase from the week before. As we've been seeing recently, the incidence continues to be highest in the younger population, or adolescent and young adult population, 20 to 49 years of age. And as I've shared before, these numbers may change as additional test results come from specimens collected during this week. So we continue to update that online. Also, at this time, as we've seen before, we're seeing a change in the epidemiologic link of COVID-19 cases. As we see increasing numbers, we traditionally have seen more sporadic cases unable to be linked back to an outbreak or a household, as you can see here in this slide. So the light blue line are those that are that seem to be sporadic. The dark blue line just trailing behind it are household contacts. Less so right now are we seeing connections to outbreaks or clusters. And finally, similar to our increase in cases, we are also seeing increases in current census of COVID patients across our hospitals statewide. So you can see we're now at a census for COVID patients, COVID positive patients, higher than at any time we've seen in this pandemic before. And we continue to work really closely with our hospitals to monitor their capacity and focus in on how we're being able to address all of the cases as well as the ongoing hospitalized patients for other reasons. Yet another important point of why the work we have to do on preventing COVID as well as influenza is critically important at this moment. So with that, we are going to transition our focus. We're going to talk about school metrics, and then we'll dive back into influenza discussion. So Dr. Jean.
Thanks. So, school metrics are not directly related to clinical medicine, but they're a really important topic for a lot of us who are maybe parents or have other connections to communities with schools, of course. I wanted to give an overview of our updates that were announced on October 30th with the Oregon Department of Education. And so they're already now in effect, and this came out last Friday. So why did we update the metrics? First of all, this was a planned update that ODE had been planning since the beginning. They wanted to have a revision and look at how the initial metrics had done. So that's why this is happening now. It's not related to anything else. And then the main reasons we wanted to update it were, the idea that having kids in school in person is one of Oregon's highest priorities. We know that there are real mental and physical health benefits, as well as many other benefits to having kids in school. We also have looked at some of the newest data, and the original metrics came out in early August, and there's since then been a lot more data and reports from around the world of schools opening, in many cases what we would call successfully opening without seeing widespread transmission or outbreaks in schools, even in places where their community transmission was relatively high. And finally, just recognizing that even though we are seeing an uptick in cases around the country, including Oregon, we know that COVID-19 spread can be mitigated by the basic public health measures that are in place in schools. And the Ready Schools Safe Learners Guidance document is, and the operational blueprints that schools are putting out there are really rigorous and detailed, and I think have those measures in place to prevent transmission and minimize the risk. And so we're really balancing two priorities here. We want to give more students the opportunity to return to in-person instruction when it poses a lower risk to students, staff, and the community. At the same time, we want to protect students, school staff, and their families from, of course, catching COVID-19 or accelerating the spread in their community. Next slide. So there are three major updates. There's certainly more than that in these metrics and also in the accompanying guidance. There are quite a few, but I'll highlight the major changes. So number one, we're removing the statewide 5% test positivity threshold. And we're doing that mainly to increase local focus. So the county test positivity will remain as an important metric. And we're also finding that with increasing testing availability statewide, we really anticipate that state test positivity is not going to be the limiting factor. Even though we are seeing increasing test positivity right now, we think that the county test positivity is a more accurate and just simpler to focus on that by increases the local focus. We also know that Oregon has many counties that are tied closely to their region or to other states even, as much or more so to the state as a whole. So that was the rationale there. Next slide. The second major update was really a way to align with CDC, align with Washington and California and many other states, and that's changing the review period. So we had initially had a 1 week, 3 consecutive 1 week period of look back. So you can see that on the left there, we had basically, you had to meet the metrics 3 weeks in a row for a 7-day period. We are now changing it to a simple 2-week average. And the other benefit to that, in addition to being simpler and aligning with other states, is that it smooths the week-to-week variation, which we were seeing that as a real issue with some smaller counties where their rates were just going up and down, based on a small outbreak or other trends, and that was really making things more complicated for them. So this is a way to simplify. Next slide. The final major update was expanding the K-3 exception to all elementary schools. And most elementary schools are K-5, but there are some in the state that are K-6. And we're also changing this from an exception to a main part of the metrics. Now, initially the evidence that came out that was out there around students, younger students, was that K-3 age may have been a lower risk for transmission. The current evidence is a lot more mixed on that, and so we made this change recognizing that evidence has changed, but we still know that younger children are at much lower risk for severe illness than older children and adults. Now, the other reason for this change is that cohorting is really much more manageable with an elementary curriculum. And cohorting is one of the main public health tools we have to minimize transmission and also to make it much more easy for for public health and schools to do contact tracing and case investigation because you have a defined cohort with limited mixing. And compared to middle school and high school where there's more individualized curricula, it's much easier to do this in elementary school. We also know that elementary age students, childcare is an important issue for this age group. And so being in school is often going to be the safest situation for these students. So in-person learning is serving an important purpose there too. And then finally, we know that remote learning is less effective for the younger students. And they really depend on in-person time for more effective learning and further development. Next slide. Okay, so here is the table from the updated metrics. And this is, again, reflecting some of the things I mentioned. We've got the county test positivity. At the top, we've got the county case rate. We also have a county case count option now. And so we've eliminated one of the exceptions for smaller counties that relied on case counts, and we basically built those into the new metrics. So if you're a smaller county with less than 30,000 people, you can go by your absolute case count as opposed to the case rate, because just a handful of cases in a small county, because of the small denominator, can result in a really high case rate. So we've also broken this down by the instructional model. So the green zone would be on-site or hybrid to maintain small cohorts. The yellow zone is kind of is the zone where a lot of schools may be for a while, and that is the elementary school age. So you have a carefully phased approach here. We'd start out with K3. You would add additional grades up to grade 6, and then potentially after 4 weeks of not seeing a lot of outbreaks or transmission in schools, you could consider adding middle school and high school. And then there's a transition zone. I'll actually talk about that more in the next slide. Finally, above 200 or above a case count of 60, a case rate of 200 per 100,000 over 2 weeks, or a case count of 60 over 2 weeks, or a county test positivity over 10%. That is basically required comprehensive distance learning with some limited in-person instruction, which is really meant to be for specific situations. It's limited to 2 hours, it's limited to smaller groups. It's really meant not to be primary instruction. Okay, next slide. So the transition zone is really designed to prevent schools from cycling back and forth rapidly between on-site or hybrid and distance learning. And so for counties that are going upward, or seeing an upward trend, as many are right now, they can stay in on-site or hybrid even into the orange zone, but they should be carefully following their trends. They should be discussing with their LPHA and really deciding, can we stay for a little bit longer, or are we really needing to transition now? Conversely, if they're in the red zone and they're declining, they really can't go into on-site or hybrid until they get to the yellow zone. So that transition zone it depends on the direction that the county is going. And the final thing I would make here is that these case counts and case rates in this table are a bit higher, a little bit more lenient than the ones that were in our previous iteration of the metrics. And that's, again, reflecting the overwhelming feedback we've gotten from many people, parents and students, about the importance of being in person. So we are allowing more students in school under these metrics. It's still going to be a small percentage, probably around no more than 20% of Oregon students will be currently having any form of in-person instruction, even under these metrics. So it's still a small proportion, and we're confident that with the public health measures in place, we're not going to see schools causing major outbreaks or transmission. That's it.
Great. Before we go on, there's one question that came up, Dr. Jean, I'll just pose to you. Nicole said, I can anticipate parents bringing their kids to the office, healthcare provider office, presumably asking for a medical excuse to keep their kids out of school, say because they have asthma. Can you address this?
Asking to keep their kid out of school with a medical excuse.
So maybe just put it other way, Dr. G, my understanding is that there should be options for parents and it won't require a medical excuse to keep your child out of in-person school. Is that correct?
Exactly. So schools, even if they're in on-site, they're supposed to allow for, if a student has any concerns, a parent has any concerns, they should be providing remote options. Now, there may be some places where the remote option, in rural areas is not going to be, ideal, but the schools are supposed to be providing that option.
And we can look there. My guess is there may be more information on ODE's website. We don't anticipate that any of these will require any kind of medical excuse specifically. Yeah. Okay, great. Thank you. Why don't we go on? Dr. Sullivan is going to talk to us a little bit about influenza and vaccine update.
Well, great. Thank you. I want to start this conversation and frame this discussion around influenza vaccination based on the numbers from last year to look at between 39 million and 56 million flu cases, 18 million to 26 million medical visits, 400 to 740,000 hospitalizations, and between 24,000 and 62,000 deaths. And as we reflect on these numbers, I think it's really important for the context where we find ourselves. A lot of people have said, I don't know if I need to worry about the flu vaccine this year because I hear that in the Southern Hemisphere, they didn't have much of a flu epidemic this year, and because we're doing all of our masking and social distancing. But I would posit that given that our numbers are going up, our stresses on our hospital beds and our medical healthcare resources are at a critical place. We can't even afford even a portion of these numbers. So we need to take the opportunity to prevent a preventable illness. So here's my pitch, my cheerleading, to encourage you, to encourage your family, everyone you know, all your staff and your patients to get your flu vaccine this year and keep those people out of the hospital, out of the doctor's office. Let's go to the next slide. There is some new guidelines because we have a potential for a twindemic, right? Flu and SARS-CoV-2. And so what are the guidelines around, do I test for one? Do I test for both? What's the guidelines now? So as of last week, new guidelines came out. And if any patient has an influenza-like illness, it's described as a temperature over 100 degrees Fahrenheit with a cough or sore throat, that's considered an influenza-like illness. And regardless of severity, you would test that person for COVID-19. Now, whether you test for both COVID-19 and influenza, there are a couple of cases where you definitely would do that. And the first, and they're for two reasons, one for treatment and the other is for infection control. So for those people who are heading to the hospital or those with severe illness, you should definitely co-test. And it will affect treatment. And also for those people who live in congregate care settings like long-term care facilities, prisons, shelters, or group homes, these people should also be co-tested because it will be important to note if they have influenza, we may likely treat other people around them with antivirals. Now, whether you treat for mild to or whether you test for influenza for mild to moderate influenza-like illness is really dependent on whether you would change your clinical management. So say you see person day 3 and it's past the time where an antiviral would be useful, you probably don't need to co-test that person. Also, is there a good availability for accurate testing? Sometimes the rapid tests have a high false negative rate. And so really consider if it's going to change your clinical management. It is important to note that co-infection with COVID-19 and influenza has been documented both in Tennessee and in California, and we will see more. But really important to remember that the presence of one does not exclude the other. In other words, if someone tests positive for influenza, that does not mean they do not have COVID-19. There's a link here that can show you where to find these new guidelines. We can go. This year, we've been seeing a lot on social media about this myth, and I heard that if I get the flu vaccine, I'm more likely to get COVID-19 and get sicker. Is that true? And the origin of that came from a British medical journal correlate study that showed that countries with the highest COVID-19 death rates also have the highest rate of influenza vaccine uptake among elderly. But we know that correlation is not the same as causation. And so fortunately, there was a subsequent study by the Cleveland Clinic looking at 13,000 patients tested for COVID-19 at the Cleveland Clinic between March and mid-April, and compared those who received the influenza vaccine and against those who did not receive the vaccine, and revealed that influenza vaccination was not associated with hospitalization, admission to ICU, or mortality. Therefore, the CDC and nearly all public health experts worldwide still strongly encourage the flu vaccine. Now, fortunately, let's go to the next slide. So fortunately, here in Oregon, we do not have many cases yet. A low percentage of cases. You can see this last week, there were only 3 cases, 2 of influenza A and 1 of B. And so this is our opportunity. This is the time that we need to get people vaccinated. Let's go on to the next slide. The good news is, and there is good news this week, and so that our vaccination rates this year are better than they have been compared to last year, about 12% better. And the only group that lags behind are the kids 6 years of age or younger. But in the other age groups, we see the 18 to 49 group has increased by 7%. The 50 to 64-year-olds have increased 15%, and seniors over 65 are up 16%. And by the end of the year, we expect an increase overall of about 12% in the state. I would like to see that even higher. So at this point, let's move on to just a brief COVID-19 vaccine update. And I'm going to briefly talk about a few things. What our Oregon's draft COVID-19 vaccination plan is about. A quick review, if some of you may have heard about the new West Coast Scientific Safety Review Work Group, and I'll talk a little bit about that. And then some recent resources on national meetings and a really interesting article that will give you the nuts and bolts about vaccine and immunology. And finally, an agreement between the federal government and certain pharmacies to provide vaccines for our most vulnerable population. So I want to start by talking about our COVID-19 vaccination program. On October 16th, the OHA submitted to the CDC its draft plan for allocating and distributing a COVID-19 vaccine in Oregon once a safe and effective vaccine becomes available. Now, Oregon's plan is really immersed in equity. It reflects the state's values of recognizing both historical and contemporary injustices towards communities of color and the disproportionate effects on COVID-19 have had on them. It recognizes the fact that we must change our approach to identifying problems and creating solutions with impacted communities. And therefore, this is a draft plan that prioritizes strong community engagement through partnerships with local and tribal public health, healthcare, and community-based organizations that reach and support our underserved populations. It's critical that we invite these partners to share the decision-making process with us if we're going to be successful getting this vaccine to everyone in Oregon. The Oregon Health Authority has begun extensive outreach engagement to these organizations to partner with us in the next steps to develop this plan, understand the needs of the community they serve, and to help us ensure our plan meets those needs. We need to recruit, enroll, train vaccine providers, and build out our state's vaccine administration infrastructure, not just for COVID-19, but for our ongoing vaccine infrastructure. Also, we're going to need these partners' help in communicating to Oregonians about the vaccine when it becomes available in our state, including information about safety, effectiveness, side effects, needed doses, groups being prioritized, and where we can get it. And with that as an introduction, I'm going to talk just briefly about 3 P's of this plan: phases, prioritization, and prepositioning. If you look at this graphic, you can see in the light blue color that the first phase is a time when we have limited doses available. So we will not be able to meet the need of everyone, and so it will require prioritization. The dark blue area, the second phase, is where we have sufficient doses to meet demand, and we will probably have increased supply, probably from multiple vaccines at this point in time, and we'll catch up those that were not vaccinated in the first group and start providing vaccine to a broader group of Oregonians with special emphasis to those prioritized communities that have been previously neglected and are adversely affected. And finally, for the third phase, when we have an excellent supply, we'll shift to routine vaccination or revaccination. As far as how we're going to prioritize, the OHA has looked at various ethical frameworks to decide how to prioritize in a limited setting, and all of the frameworks, whether it be the World Health Organization, Johns Hopkins, the National Academies, or ACIP, put as the first group, the 1A group, the healthcare workers who, no matter what they're set in, whether it be in hospital or outpatients or home care, long-term care facility, and first responders. And this has, it's obvious because they're putting themselves at risk, but it also has this multiplicative effect. If we can keep this population healthy, prevent them from getting COVID-19, we keep our healthcare resources so that we can adequately address this pandemic. So that's why they are the 1A group. The 1B group will be essential workers, people that keep our community going. That could be food production, transportation, education, and those at particularly high risk, those with pre-existing conditions or the elderly. And this is the tricky part where as we gather our advisory committee to discuss the system that will best decrease death and infection, we're looking into allocation tools that will prioritize to those populations that have been disproportionately affected. The prepositioning piece is something that's changing day by day, and I was on a call yesterday, but last week we were told to be ready by November 15th to preposition some portion of our vaccine. Now, no vaccine has been approved yet, but they are prepositioning vaccines that are likely to go through an approval process so that we have them ready to go as soon as an EUA or a license is granted. And so this creates some challenges because these are the ultra cold vaccines and some logistic challenges. So we will wait and see how that goes. Let's go on to the next thing. One big positive that happened last week was that on the 27th, Governor Brown announced that Oregon will be joining California, Washington, and Nevada to provide a fourth level of scrutiny as a part of the COVID, it's called the COVID-19 Scientific Safety Review Work Group. Now, this is in addition to the normal standard safety review that we do every time a vaccine comes out in Oregon. The senior health advisors review every vaccine for available data on vaccine safety and efficacy and the ACIP guidelines. But in addition, there are 3 other standard areas where safety and efficacy are independently vetted by scientific groups. The first is the Data Safety Monitoring Board. This oversees the manufacturer's trials. And they are the ones who can stop trials if they are seeing safety incidents or unblind the trials to see, to look at efficacy. There's the Vaccines and Related Biological Products Advisory Committee to the FDA. And they are the ones who look at the FDA's guidelines for an EUA or license and questions deeply about the process and approval. And then third is the Advisory Committee on Immunization Practices. That is an advisory committee to the CDC. So there has been a lot of interest in guaranteeing that the vaccine that we get here in Oregon is safe and effective. And so Governor Brown's announcement, October 27th, was a welcome announcement that we would have yet again a fourth level of scrutiny before Oregonians would see a safe and effective vaccine rolled out. So I wanted to, there were a number of questions after our last update, and Dr. Smits kindly gave me this article from the Lancet that is excellent, and it reviews the immunology associated with how the immunology works and its relationship to the vaccines going through the phase 3 trials. It does get into some of the weeds, but for those of you who are interested, it's very, very helpful. I also put the links to the 6-hour VRBPAC committee meeting and the ACIP meeting. And it will lead you to a place where you can look at the agenda, and then there is a YouTube link because these are all recorded, and so you can listen to any part that you're interested in. But it covered activities such as NIH activities in the development of COVID-19 vaccine, how manufacturing is monitored, and lots of information about safety, vaccine safety, monitoring before and after authorization, vaccine communication strategies to hesitant communities, vaccine hesitant communities, and some information on new upcoming vaccine trials. Probably the most critical part of the meeting were the members of the committee questioning the FDA and the CDC about the license versus EUA. And what we know is that the FDA in October has set some standards for approval for an emergency use authorization. And that includes that the vaccine has to be at least 50% effective. And the endpoint that they're looking for is prevention of COVID-19 disease of any severity, and that the safety and monitoring has to extend at least 2 months for a median of the participants who've completed the vaccines. If any of you are interested or have specific questions, I'd be happy to answer this, but these would be some great resources for you to reference. But we're hopeful. We're hopeful that we'll get a safe and effective vaccine here to Oregon relatively soon. And the last slide, I want to talk to you about another good news thing, and that is that the federal government has made some agreements with Walgreens, CVS, and I believe some other pharmacies now to provide on-site vaccination for residents of long-term care facilities, but not only long-term care facilities. It might be congregate care settings, foster homes, and so forth. And this is a huge help to us in Oregon to get to these very difficult at times. And they will take the vaccine to the person and to the people and the staff. They will take care of all of the vaccination requirements, including information systems. And they will do it over approximately 2 months, and we'll do 3 visits so that they catch anyone that they had missed. But this is really going to help our most vulnerable population. This is the group. These patients are the group that are about 44% of our deaths here in Oregon. So this is really good news for us here in Oregon. And that's that.
Thank you so much, Dr. Sullivan. I am going to just walk us very quickly through the pediatric report, and then we're going to pause for some of the questions before we go on into the literature review. So I just wanted to make sure you're aware, we've been periodically updating our pediatric COVID-19 report for Oregon, and it was last updated the end of last week, October 30th. So just a couple key findings. One, over all the COVID-19 cases through this October 28th, under age 18, there have been a total of 11.3% of those are among children, 18 and under. There continues to be a very small percentage of those cases that are hospitalized at any time during their disease, 1.3% for pediatric cases, and that's in comparison to 8% of adult cases. And we now have had 6 cases of MIS-C or multi-system inflammatory syndrome in children reported in Oregon. You can see in the background here, this is the pediatric epi curve. It somewhat mirrors, of course, the overall state epi curve, but you can see that there's been quite a number of pediatric cases of COVID, including in this most recent surge in cases. And just briefly, one more note from our pediatric report. It shows, again, similar to before, that the majority of pediatric cases are in the older age group here. You can see in the top graph, the 0 to 5 age group is on the top, 6 to 11 in the middle, and then 12 to 17 on the lowest bar graph. And those are where we see the most cases of COVID-19. You can also see here representation of the proportion of those that have been hospitalized versus not hospitalized. Of course, recognizing again that the numbers of hospitalizations have fortunately been quite low. And then on the very bottom, also pulling out to show that the epidemiologic links for pediatric cases are quite different for adult than compared to adults, and that the majority of pediatric cases have an epi link to another household case. A smaller percentage are related to an outbreak, but that is the next common. And then, sporadic is the next, and then outbreaks and so forth. But again, the most common situation is a pediatric case related to a household contact. So I invite you to take a look at that as well. A couple questions that we've come up with, team, that I'll see. There's been some great questions. We'll try to get through some of these. Maybe on this pediatric and school metrics note, there was a question, if I can get back to it, if there's any more information regarding the evidence of transmission of SARS-CoV-2 in pediatric populations. I know this has been an area of a lot of evidence forthcoming. Anybody want to chime in to share what we know of most recently?
Well, I recently looked at evidence for school transmission. I know that Dr. Sullivan had done a review a while back of children in general, but I think the conclusion was there's from that children can certainly transmit, and the rate may not be any lower than older populations. But again, when it comes to a structured school setting, we are not seeing major transmission events worldwide, really. With just a few exceptions.
Yeah, I think that's absolutely true. I think that there's been a lot of examples about schools that have good structures in place to prevent infection do very, very well. And where kids tend to spread it is in the household, if they do spread it. And they are not as likely as say, for instance, young 20 or 30-year-old to spread it to friends. The children are more likely to spread it within families.
Great, thank you. Another question that just came up is, for the pediatric data, what about disease severity for infants under age 1? And I don't have the answer to that. I haven't been able to look at our data disaggregated in that way to look at the 0 to 1. We're going to hear a little bit about a literature update about neonates and impact from SARS-CoV-2 in pregnancy and a maternal SARS-CoV-2 infection. But I can't tell you from our Oregon data much about that at this point, but that is an important question.
There was a report from China early in the pandemic, and they had an extraordinarily low rate of hospitalization in their under ones. I think it was like 6 total. I mean, it was really strikingly low.
Okay,
so
thanks. I'm going to go to testing. We haven't talked a lot about that today, but there's a couple of questions that have come up that I think we want to make sure we can address. So early on, there was a question hoping we could clarify the value of the Binax Now tests, such as information about false negative rates. There's confusion out there. Can we talk about the role of Binax Now tests and what we know currently about false negative rates?
Yeah, I don't think I have an update on that. The initial validation studies for Binax Now showed that they had pretty good sensitivity and specificity in the 90% for each, not 90s, I forget the exact numbers. So, for false negatives, we're talking about sensitivity. And the sensitivity in these studies is compared to PCR in pretty much every case. And again, we have concerns with oversensitivity of PCR at the tail end of the infection, where people may be PCR positive for weeks after their symptoms are resolved, and they're no longer infectious, as documented by viral culture. Although viral culture is not exactly does not exactly correlate to infectiousness, it's pretty close, we think. So, in any case, in general, antigen tests are less sensitive than PCR. However, the public health relevance of that is still unclear, and we think that Binax Now is actually probably a pretty good test from the standpoint of false negatives. But one final caveat, that's really the study, the tests have been studied in symptomatic populations. So if you're using it for screening, it's kind of an off-label use of the test at this point, and we really don't know. We don't know.
Great, thank you. Just a couple more testing questions. So this was in relationship to testing for influenza and COVID. The question is, should we be testing using multi-respiratory virus testing or panel in addition to COVID-19 and flu?
Like adding RSV and other respiratory.
Yeah, there are some panels that are coming out that include COVID-19, influenza A and B, and RSV. I think that in the right circumstance, that can be super helpful. Again, if it's a seriously ill person, someone who's going to be hospitalized, or someone who lives in congregate care setting, I think that makes a lot of sense. I do think we have to be prudent about our resources and make sure that it makes clinical sense to do so. But I don't think doing a broad viral respiratory panel, which is very expensive, is useful or prudent.
Yeah, we do have some specific language on this in our point of care antigen testing guidance. So if somebody is negative, but it's a patient who they're negative on an antigen test like Binax now, but they have symptoms and you have a high clinical suspicion, we say you should consider retesting and testing for additional respiratory viruses, including influenza, but that could certainly include a respiratory viral panel.
Great. Thank you. One other question, this one is news information to me, so let's see. The questioner is asking us to comment on the requirement of 2 tests for overseas travel, such as antigen and antibody. Why and when do you need both tests?
Boy, that's a good question. I haven't heard of anybody requiring both antigen and antibody. They're quite different. We're generally not recommending antibody testing for clinical purposes or public health purposes at this time.
We'll have to look into who's requiring that out there, but yeah, we generally are not recommending antibody testing routinely right now. So if you have more information on the source of that requirement, please do let us know. It will help us track it down a little bit. And then there's a couple questions, and then we'll move on to literature, just about contact tracing and refusal of reporting contacts. Anything we can say, I know there's a lot of questions out there, anything we can say about how that's going right now in terms of people getting contact, investigated when they become a case, and reporting of contacts, follow up with those contacts. Do we have any information about how that's going in Oregon?
Well, we know that we're only able to contact a portion of all the contacts, and we sometimes just can't get the information from the case. There are some cases that we're not able to contact despite repeated efforts and different modes. So it's always going to be imperfect. I think the broader issue right now is that with our increasing case trends and our current resources for staff and training, we're concerned about local public health's capacity throughout the state to stay on top of contact tracing. And I think that is just the reality. We've got such a broad prevalence now that we may need to adjust our thinking, because for diseases with broad prevalence like influenza, we do not do contact tracing. It's such a Herculean task to do that. So I think we're going to have to look at that closely, and this is something that all the states are facing right now.
Great. So there's some really good information that we have to share from the literature that I think will be helpful. So we're going to pass it to Dr. Smits, and then we'll see if we have any additional question time. So go ahead.
So the first thing that I wanted to highlight for the literature review was a pair of papers that came out in the MMWR, which is the CDC's publication. It came out this week. They were looking at maternal and infant outcomes. So they had 23,000 or so pregnant women with symptomatic COVID-19, and compared to non-pregnant women with symptomatic COVID-19, they had a pretty significant increase in their risk for ICU admission. So their adjusted risk ratio is 3. as well as for mechanical ventilation and for death, unfortunately. And outcomes were worse in women of Asian, Pacific Islander, Hispanic origin that compared to Caucasian or African American women. And then they paired this with an article about birth and infant outcomes. So they only had about 4,000 births with known gestational age, and about 13% were preterm, which is pretty significantly different than the overall U.S. population, which is about 10%, which might not be surprising if the symptomatic, if the ICU admissions and things like that are much higher. But even among term infants, 9% were admitted to the intensive care unit. So that's pretty significant. And then 9 neonatal deaths are reported. That's too small a number to really be able to say anything about or to kind of say what they had actually died of, and they didn't have a lot of information in the paper. So my takeaway from these 2 articles are that if you care for pregnant women or women who could become pregnant, really stressing the need to prevent them from getting COVID-19. So making sure they're wearing masks, making sure that they're trying to keep their bubble as small as possible, and washing their hands and using all those other really good techniques. And again, echoing Dr. Sullivan's point, making sure they and all their family members are flu immunized so that they don't have that extra whammy, which we know is also very, pregnant women usually get much harder hit with the flu if they get it. So hopefully we'll be able to do that. Next slide. So the next 2 slides were just, there's a couple of slides. I was asked about mask mandates. So a mask mandate is not necessarily how many people are wearing masks, but the government, whether it be a state or a city or a county, saying that you have to wear masks indoors. So it's just the government policy of wearing a mask. And again, in the MMWR, they had an article looking at different mitigation measures. They found that the number of COVID-19 cases in Arizona stabilized after and then decreased after they implemented and enforced a statewide mitigation measures. So it was a series of different policies, multiple different mitigation measures. But one of them that they felt was the more important piece was an enforcement of a mask mandate. And notably, they saw the effect about 2 weeks later, which is what you would expect given the incubation period of COVID-19. And then widespread implementation and enforcement was, including mask wearing, can definitely help decrease the numbers of COVID-19. Was the sort of conclusion of this particular article. Next slide. So then the next 2 slides are actually unpublished reports. So they have a ton of caveats. They are not peer reviewed. They may not have had all of the different controlling factors, et cetera, that you might see in something that's published. But I felt that they both had pretty striking results, and I felt that they were really interesting and wanted to bring them to your attention. So the first is out of Kansas. There's a link at the bottom if you want to look at it. And it's actually a really interesting slideshow. They have some pretty compelling slides in there with rates and their graphs. So in Kansas, the governor had a statewide mask mandate like in Oregon, but the Kansas Supreme Court ruled that to be unconstitutional. So many of the counties opted out of it. And so they ended up with a map of counties. Some had mask mandates, some did not, and some had it for a period of time. So they looked just at the counties purely without mask mandates versus the ones purely with mandates. They got cell phone data and controlled for sort of some mobility. They didn't control for other things. So counties that had mask mandates may have been different in other ways, and may have had other mitigation measures that they didn't mention. But essentially, they had that 2-week lag that you saw in the MMWR article, and then their COVID cases were about half of what they saw. So for counties that had the mask mandate, their cases were about half compared to the counties without mask mandates. And the counties without mask mandates, if you go and look at the slides, they were actually always on sort of an upward trajectory versus the ones with the mask mandates that were pretty flat once they stabilized.
I would say if I were on the peer review for this article, I would tell them they should not be using that language that it reduced it, because that implies they know there's causation. I would say that in counties that had a mask mandate, there was an associated reduction 2 weeks later, and we don't know for sure if it was because of it. Certainly could be, but gotta be careful with their use of the terms.
True, and this is more of a policy piece, I think, than a scientific piece. So if you want to go to the next. And that may have even been my word instead of their word, in which case I mea culpa. The next one comes out of Vanderbilt, and this was looking at hospitalization data. Same type of thing. In Tennessee, some counties have mask mandates and some do not. And then they were looking at their hospitals. They zip coded data. They got zip code data on the origin of so when you were hospitalized, they knew where the COVID patients, which counties they had come from. And hospitals that mostly took in patients from areas without mask mandates had a 200% increase in hospitalizations. And then counties that drew mostly from areas with mask mandates were stable or decreased in their COVID hospitalizations. Again, not peer reviewed. This is just it's not a causation article. It's just a association. There was other mitigation measures that varied, like restaurant openings and things like that. And there's no information about the people that they hospitalized, whether they were actually wearing masks. It was just about the government policies. But taken together, that it was just really striking to me that these two states were showing that if you had a mask mandate, you significantly saw a lower COVID rate and a lower hospitalization rate. So I think that's really important as we talk about policies in our state and in our communities. Next slide. Oh, and before we go on, there was one other additional thing that occurred to me as we were going through the slides that I wanted to mention, and there was no slide on this. I know that Dr. Harganani mentioned the MISC-C, the multi-system inflammatory. So in children, we've had 8 cases. I just want you to be aware that the CDC has published a case series now of MIS-A, so multi-system inflammatory syndrome in adults. So just to be aware that that does exist. The OHA has changed our payment policies. We will pay for antibody testing for adults who are hospitalized who are being considered for MIS-A, because about 1/3 of patients in the MMOWR report only were diagnosed with antibody tests. And also, it's a case series of 27 patients. 26 of them were from minority communities. So that was another really kind of important piece of information. So sorry there's no slide on that, but I just...
We'll try to bring that up for our future one, just to make sure everybody's aware of the adult experience with this.
Yeah. So then we were trying to answer your questions. A question came up about pulse oximetry, particularly if you have a patient with COVID, should you let them go home with a pulse ox and kind of monitor them to see how they're doing at home? And so to look into that, you have to see whether pulse oximetry works. So this is a really interesting study from 2016 in one of the anesthesia journals. And so the pulse oxes that most people buy are not FDA administered. So the FDA approved pulse oxes are usually $150 or more. They tend to be quite, they're trustworthy with a lot of caveats, but the ones that you buy for 20 bucks off Amazon are not FDA approved. So they tested, you see the series of, I think, 6 different models. I would hate to have been a person in this study because you had to have an arterial line to draw your actual oxygen level. And they found that they did pulse ox readings compared to all these different blood samples, and the pulse oximeter showed a huge error. So it started out with it could be as high as 6% and then once you get, the lower your oxygen saturation, the higher the rate of error. Bringing you way back to basic physiology in medical school. You'll remember that oxygen saturation is a
S-shaped curve?
Yeah, an S-shaped curve. So if your oxygen saturation falls from 98 to 97%, that's actually a very low drop in the amount of oxygen carrying capacity. But if it drops from 90% to 89%. It's actually a much higher drop because of the exponential S curve. So
Sigmoidal, is that the word?
yeah, so once you get below 90%, these pulse oxes were not accurate, and that's where we really care, because that's where you really start to see a difference in oxygen carrying capacity. So based on this, I wouldn't recommend that anybody relies on a home pulse ox. They also had tons of other caveats about you have to only use the middle finger, and it can't have fingernail polish, and you have to have no peripheral vascular disease, and there's tons of other things that also you have to consider as well. Next slide. And then there was another study in 2020 looking specifically at COVID-19. So the study, the last slide was just kind of a pure academic, are these things worthwhile before the epidemic and all. This one was looking at COVID-19. And they, again, that 90% threshold is really important. And they found that basically there's huge variability depending on the temperature in the room, the person's temperature, peripheral vascular, there's all kinds of factors, and that basically not to use non-FDA approved pulse oximeters. Next slide. And just to pound this point home one more time. So the Center for Evidence-Based Medicine at Oxford, highly recommend their website. They do some really, really good rapid reviews. They looked at smartphone technology. So I know a lot of Apple Watches and things now are reporting oxygen saturations, and they found their conclusions were that you should not trust those, that they are really faulty. So unfortunately, I don't think we have a way of really monitoring people's oxygen saturations well at home. And I think that's our last slide. Am I correct?
That's helpful. Thank you.
So we are just out of time now. I really want to just make sure everybody's aware that we are changing up our schedule in November and December, and we'll continue to assess the frequency moving into 2021. Hard to say that. So there are 4 more webinar sessions for healthcare providers throughout November and December, a little bit less than previously. So today, of course, is OHA's webinar. We'll have the Project Echo hosted by OHSU on the 12th. We will host another one of these webinars in early December on the 3rd with another Project Echo on December 10th. All of these will be posted on our website, and please continue to take a look at our website for new information coming out as this is a rapidly changing time. I also just sent some more information about where to find information on up-to-date PPE recommendations, as well as COVID exposure and excluding from work for healthcare providers. That was a question that we didn't get to today, but I just shared with you information about where to find that. So thank you for your time today. We will look forward to joining you again in these upcoming webinar sessions. And please, again, be safe, work with your friends and colleagues around preventing further spread. And thank you for all the work you're doing. Have a great day.